Hello again, Dr. Jordan Taylor, undergraduate exercise science program director and associate teaching professor at the University of Kansas. On today's episode of Fitness Facts, we have my buddy Adam Steele back in the studio. Adam is a biochemist and the founder and chief executive officer of Pinnacle Health and Performance. Adam's wife, Adriana, is co-founder and COO at Pinnacle Health and Performance, and patient care is overseen by medical director Dr. Evan Branscombe. Services provided to patients by Adam and his team include personalized treatment protocols for health optimization, hormone optimization therapy, peptide therapy, injury prevention and recovery, sexual health, anti-aging, hair loss, and weight loss. Treating patients who are needing to control type 2 diabetes or lose weight with GLP-1 receptor agonist medications will be the topic of our conversation today. Welcome back to the show, Adam.
Thanks for having me.
All right, so we've talked about hormone optimization therapy and peptide therapy in previous videos. So today the focus is on GLP-1 receptor agonists, that is Glucagon-like peptide 1 receptor agonists, mouthful, which are drugs used to treat type 2 diabetes, obesity, and for people seeking to lose weight. So GLP-1 or GLP-1 receptor agonists display a diverse range of physiological functions as shown in this image. And I guess I should mention, where GLP-1 is endogenously produced. So you have these cells called L cells in the intestines, really at the terminal end of the small intestine, you have the ileum. And then also in the large intestine, you have those L cells, and they secrete this GLP-1. It's also produced in the brainstem as well. So what are some of the effects of GLP-1? Or if you're using a GLP-1 agonist, right, that we're going to get into talking about. Well, with the gastrointestinal tract, there in the upper left-hand corner, you see that GLP-1 receptor agonists can decrease gastric emptying. So basically, food is being more slowly released from the stomach and into the GI tract. So you would remain feeling full longer, right? A little bit of a decrease in gastrointestinal motility. So you're not moving that food and waste along as rapidly. So again, it's going to help you feel full for longer. If we move to the brain, it has effects there at the level of the central nervous system. So decreasing appetite. Obviously, that's going to help you regulate your caloric intake so you don't overeat. Increasing satiety. So again, feeling more full and satisfied so that you're not as likely to eat and gorge on huge meals. I'm not going to hit on every little thing here, but just some other points. With the pancreas secretes insulin. After you eat a meal, your blood sugar rises, and insulin is secreted from the pancreas to basically store that sugar in your liver, your fat cells, your muscle. So insulin is a storage hormone, and it helps to regulate your blood sugar level and keep it at an appropriate level. And so GLP-1 receptor agonists can enhance insulin secretion from the pancreas, which is going to, again, help to keep your blood sugar levels stable. All right. And it also decreases glucagon secretion, which glucagon is a counter-regulatory hormone to insulin. So if the pancreas is releasing glucagon, that's going to cause an increase in blood sugar, right? So by decreasing glucagon secretion, you're going to have reduced gluconeogenesis and glycogenolysis in the pancreas, which means you're not going to have that signal to raise blood sugar levels. Okay, so it's keeping your glucagon low, keeping the insulin level higher. That's going to help, again, stabilize blood sugar. And then at the tissue level, at the liver, the adipose tissue, and muscle, GLP-1 receptor agonists can enhance insulin sensitivity. So not only are they helping to increase insulin secretion, but where that insulin exerts effects on at the liver, adipose tissue, and muscle, they're more sensitive to it, right? Which is a good thing, especially if you're a type 2 diabetic, because what do type 2 diabetics have? What's a hallmark feature? They have reduced insulin sensitivity. So their cells in the liver and adipose tissue and muscle are resistant to insulin, which is why blood sugar remains high. But in this case, these GLP-1 receptor agonists are going to actually help to not only increase the insulin secretion, but the cells of the body are going to remain more sensitive to it. So basically, it's easier for sugar to get uptaken into those cells, cleared out of the bloodstream. And then it has other effects. So you look at, again, liver's going to produce less glucose. Part of that's as a result of the decreased glucagon secretion. Adipose tissue, I've seen different effects. I know they're studying this more in adipose tissue, but it looks like in the visceral adipose tissue, you see increased lipolysis. That's missing an L in there, but increased release of fat from visceral adipose tissue. I've seen in subcutaneous fat, there may be some lipogenesis or fat storage, but the main health benefit here is you're reducing visceral adipose tissue. And they do see in people that are using the GLP-1 receptor agonists, like the fat cells, the adipocytes actually shrink. Part of that, if it's visceral, could be due to the lipolysis, the release of fat, but also you have the other effects, right? The appetite reduction, suppression, feeling satisfied after a meal. So you may not be taking in as many calories. If you're not taking in as many calories and you're eating in a caloric deficit, yeah, those fat cells are going to shrink. So you have that beneficial effect on adipose tissue. And of course, the enhanced glucose uptake, you're getting that glucose removed from the bloodstream, right? You don't want high blood sugar levels because that can be very damaging to the cardiovascular system. And then in muscle, enhanced glycogen synthesis. So you're uptaking glucose out of the bloodstream, but then tacking those glucose molecules together and storing it as glycogen. Now you've got a reservoir in muscle for when you go exercise of stored glycogen to get you through those high intensity exercise bouts, right? So it enhances glycogen synthesis in muscle, enhances glucose oxidation. So that's just the burning of glucose through, glycolysis, the Krebs cycle, electron transport chain. We talk about it in my classes. I won't go into it detail here. But again, burning glucose in the mitochondria to produce ATP, the energy for your muscles to contract and work during exercise. That's enhanced. And then you see with the heart, decreased blood pressure, increased heart rate, increased myocardial contractility. So the heart muscle can literally contract with more force. And then in the kidney, increased natriuresis, so that's just the removal of sodium from the blood in the urine, right? So keeping your sodium levels in check in the blood, that's obviously important for blood pressure regulation, okay? So a lot of physiological effects there. I mean, it's pretty amazing, whether it's, this endogenous GLP-1 released from the intestinal tract, or as we're going to get into, we're going to talk about some GLP-1 receptor agonist medications, and I'm going to kind of turn it over to Adam. So we'll get into this next question here. So which GLP-1 receptor agonist medications are typically prescribed to, your patients who are looking to treat their type 2 diabetes? Maybe they're just wanting to lose weight. And obviously there's a lot of methods to go about that, but which ones are you going to typically, you guys at your team at Pinnacle going to prescribe?
Yeah, so typically we either use Semaglutide, which is more commonly known as Ozempic or Wegovy. It's the same active medication. Ozempic was when it was originally approved for use in diabetes. Wegovy is when the FDA reapproved it for obesity, for weight loss purposes. And then Tirzepatide, more commonly known as Mounjaro. Those are the two big GLP-1 agonists that we use, and it's one of our most popular medications. Outside of hormone replacement therapy, the GLP-1 agonists are probably the most widely used medication we have.
Okay, and then again, just how are they administered, typical protocol for each of those medications?
So both of them are once a week subcutaneous injections. Again, tiny little insulin needle, nothing huge, just, generally love handles is where I tell people to do it. Once a week, and both have a standard protocol that involves tapering up the dose slowly. For example, semaglutide, you'll start with 1/4 milligram a week for 4 weeks, and then it goes to 0.5 milligram a week for 4 weeks, and then 1 milligram a week for 4 weeks, and then 1.7, and then 2.4. And we don't always get up to the higher doses, but part of that is because hands down, the number one side effect that's reported is nausea, is post-injection nausea, which is very common. Generally, it goes away after 2 or 3 weeks. So it's, after you've done a couple injections, it's really not bad. And again, that's why we taper up, so we can kind of minimize the nausea from it. I always tell people, just do your injection at night, right? Like literally put it on your nightstand, do your injection right before you go to bed. You sleep through the worst of it. But again, it's once a week. It's not terrible, but they're both once a week subcutaneous injections. Okay.
And kind of get into the next question. I mean, any other adverse side effects patients should be aware of? Like, is nausea the main one that you hear about a lot?
Nausea, just GI distress. So diarrhea is common. I wouldn't even say common. It's normal to experience, but it probably occurs in 20 or 30% of cases. But again, we try to taper those doses up slowly so the side effects are minimal.
Right, that makes sense.
And there's a number of other side effects that we've only seen in rats and mice, like we haven't actually seen in humans, like gallbladder inflammation. So again, there's a number of things that we look out for, but haven't happened in humans yet. So not generally a huge concern.
Right. And then I guess for how long are patients typically treated with these GLP-1 receptor agonist meds?
Generally, it's a longer period of time. We have people that will get to their goal weight and will stop. We have people that kind of find a maintenance dose, so to speak, and just kind of stick with a smaller dose weekly to control their appetite. But generally, the longer somebody's on it, especially with some of the benefits we'll talk about, like leptin sensitivity, the longer you're on it, the easier it is to maintain those changes after someone stops.
Okay. So, in addition to prescribing medications, I know you counsel patients on the importance of changing their lifestyle in order to lose weight, controlling their blood sugar, and improving their overall health. Kind of what specific diet and exercise recommendations does your team at Pinnacle Health and Performance suggest for patients? Because, a lot of, not you guys, because I know you guys are holistic, but a lot of physicians will just focus on a drug. Like, okay, we're giving them the Ozempic and see ya, right? How are you guys different in that regard?
We just try, it depends obviously on the patient and what their goals are. But the biggest thing about the GLP-1 agonists that we've seen is because they're so different from traditional weight loss meds, appetite suppressants like phentermine or phentermestrazine, which are CNS stimulants. There's a lot of people that don't do well with CNS stimulants or don't want to feel jittery. In a lot of those, once you stop, it goes right back to where you were, and you regain the weight.
It's like people that quit smoking. Smoking is a CNS stimulant, and once they quit smoking, my appetite's back, and then they were skinny when they were smoking,
right?
And then they put on that weight. Mm-hmm. Yeah.
So, but like you said, one of the biggest effects from the GLP-1 agonist is resensitizing people to leptin. So leptin's your satiety hormone that gives you that signal, your brain that signal that says, hey, you're satisfied. Generally, people that are insulin resistant are also leptin resistant. And, a perfect example, literally yesterday I was talking to my brother. My brother just got back from Australia, and he was talking about how their portion sizes were so much smaller. And it makes perfect sense because they're not leptin resistant like most of the American population is.
Right.
They don't have to overeat. You get Americans that overeat too much, and all of a sudden you have to eat more and more and more in order to get that same satiety signal, whereas all these people in Australia aren't leptin resistant, and so they don't have to eat an ungodly amount in order to feel satisfied. So we see people like it almost forces people to make changes in their lifestyle, because all of a sudden they can't go to a restaurant and finish one of those big meals, and they can't go to Chipotle and finish the whole bowl. And
they know going in, I don't need to order as much. Right.
Yeah, you learn that quickly, because what it's talking about side effects. Nausea is obviously the big one, but if you're on one of the GLP-1 agonists and you do overeat and way overdo it, you will feel terrible, and you're like, I don't want to do this again. So, like I said, it almost forces people to make lifestyle changes. One, because they don't have to eat as much to be satisfied. Again, it slows gastric emptying, so they're going to feel fuller longer. So you have you're working through the brain, through the nervous system with leptin. You're also working mechanically through slowing gastric emptying. And then obviously you have the benefits of increased insulin release from the pancreas and decreased glucagon. So, it keeps your blood sugar stable. But, the biggest thing I always tell people...
That's a question I got to ask. And I don't know, is it ever used in conjunction with, some type 2 diabetics, of course type 1, they're on insulin, they have to be on insulin. But some type 2 diabetics, like if they've had it for years and hasn't been controlled well, they may need insulin injections. Is this ever used alongside insulin? Or do you guys?
We haven't done it.
Yeah.
No.
Yeah. Okay. Just out of curiosity.
We like it because, you get opposite effects with insulin and with GLP-1 agonists. You get the opposite effect on insulin sensitivity.
Yeah.
So using insulin is going to make you more insulin resistant. The GLP-1 agonists are going to resensitize you.
And that's what happens in type 2 diabetics. Their cells are so insulin resistant, the pancreas is just saying, oh, I need to make more. I need to make more. It's like when if my daughter doesn't listen to me, at first I'm calm and cool, and then I have to keep raising my voice. It's like, because she's resistant, I have to yell and get my point across. It's kind of like your cells with insulin. It's like, you see in type 2 diabetics, these super high levels of insulin in the blood because the cells are not responding. The pancreas is like, I got to make more. I got to make more. I got to make more. So they will listen and actually uptake that sugar out of the bloodstream. But you don't see that with the GLP-1 agonists because it increases the cell's sensitivity to insulin.
Right.
So why would the pancreas need to make a ton of it? I mean, it'll enhance the release, but not like you would if you're, obviously taking
your body.
insulin.
Yeah, it has to use less insulin to get the same effect.
Right.
So, but yeah, the biggest thing is it kind of forces people to make lifestyle changes. And because you're resetting someone's insulin sensitivity, you're resetting their leptin sensitivity, generally it's much easier for people to maintain that weight loss, to maintain that lifestyle after they stop versus, a CNS stimulant that as soon as you're done, you go back to where you were.
Right.
You reset your leptin sensitivity. All of a sudden, as long as you keep things under control and you continue with that healthy lifestyle, it's going to be much easier to maintain those
and you
changes.
try to pull them off. Like, let's say they hit their goal body mass index, their goal weight, their goal body fat percentage, whatever it is. Their blood sugar levels are stable. You try to pull them off and say, okay, like, you've got an exercise routine established. Your portion size is under control. You're eating a lot healthier. So let's see how you do off of it. Okay.
Yeah. And like I said, some people come off. Some people just find a maintenance dose that is right for them.
Right.
So, but the biggest thing as far as like what we recommend as far as diet goes, obviously the medication is going to make you change your diet in certain ways, is that you make sure people are eating enough protein. Because you got to be careful, because you can kill someone's appetite too much to the point where all of a sudden your metabolism starts slowing down because they're not, they're eating 1,100 calories a day.
Right.
Your metabolism's like a steam engine. You got to keep it fed.
They're wasting away, losing muscle, which you obviously want to. Anybody losing weight, it's like you want to maintain muscle but lose fat, right? So, yeah, high protein, get your strength training, get your cardio in each week, in addition to the medications. And then it's interesting, just to talk more about leptin, and I talk about this in my exercise biochemistry class, because leptin is really, I have a whole lecture on like leptin resistance, and we talk about it. But, you hear about insulin resistance all the time, but leptin resistance is much less commonly talked about. So it's like your fat cells, people think fat cells is just they store fat. Well, they actually release what are called adipokines and these hormone-like substances, and leptin is one that they release. So in fat cells that are full of energy, full of reserve fuel supply, full of fat, they release a lot of leptin. The problem is they found this in people that struggle with weight, that are overweight, obese, see it in type 2 diabetics. But yeah, their fat cells are cranking out leptin and releasing a lot of it, and that leptin's getting into the blood, going up to the hypothalamus, binding to receptors there, and telling the hypothalamus, it's knocking on the door and saying, hey, we got plenty of energy stored in the body. Like, there's plenty of fat here. And normally that would cause a satiety effect, right? You would reduce appetite. But in obese individuals, those are type 2 diabetic, the hypothalamus and the receptors there are resistant to leptin. So they're not listening to it. That message is not getting there to the brain, the hypothalamus. So they never get the satiety signal. They don't feel satisfied. They want to keep eating and eating more frequently, larger meals. And then that weight's just going to keep coming on. And then the fat cells are kicking out more leptin, but the brain's not listening. And you have this positive feedback loop, and it's tough to get out of it. So,
yeah, brain doesn't hear that I'm good signal, and you have to turn up the volume, so to speak, in order to. And it's just it's a vicious cycle.
Yeah.
So with resetting someone's leptin sensitivity, you're breaking that dopamine punishment cycle that we go through with food, and people just they are able to make amazing changes. I have people that will literally text me and say, like, I've tried every weight loss, every diet, every weight loss med, every this and that, and I would starve myself or kill myself to lose a couple pounds here, and then, I gain it all back. And now they've lost 30 pounds on one of the GLP-1 agonists. I think we probably have at least 30 patients that have lost 30 pounds or more on the GLP-1 agonist, if not more. It's as far as weight loss goes, we haven't seen anything like it.
And I guess because it's non-hormonal, it's going to be safe for pretty much, is there any patients that's not really, safe for?
We don't recommend it during pregnancy.
Right.
Not because it's, hey, this is bad, it'll do this. It's because we have no information on it.
Right.
We just don't have any kind of data as to how it affects pregnancy or a fetus. And so it's,
Right.
But that's a great transition because it's, the GLP-1 agonists are great as the base to a postpartum regimen.
Right.
So, you get moms that have a baby and are trying to bounce back to where they were. My wife is the prime example of that. She gave birth to her fourth less than a year ago and looks like she could step on stage right now.
Yeah.
So just the postpartum journey, GLP-1 agonist it's definitely a base of that protocol. Obviously with, postpartum, you have to talk about fluctuating hormones and estradiol and progesterone going all over the place, and you have to kind of, corral those.
Right.
But the GLP-1 agonists have been incredible in that sense as well.
Okay. All right. And we kind of talked about it. It's obviously important for patients to establish a healthy pattern of eating, incorporate more exercise into their life while taking these drugs. I think we've hammered that home. So maybe we go on to how soon after starting treatment do patients see beneficial effects and results when really they're combining, like you said, you're trying to take this holistic approach where they're combining the GLP-1 receptor agonist drugs with the changes to their diet, increasing their exercise. What's a typical timeline there for seeing those results?
Honestly, it's kind of what I tell people with like testosterone. You give it 4 or 5 weeks. I had a patient call me about a week ago. It's like, yeah, I've lost, I've been on it for 4 weeks, 5 weeks, and I've lost like 3 pounds. Like, it's been okay, but and then he called me a week later and said, I've lost 1.5 pounds a day since I talked to you last. And it's like, there you go. Sometimes it just takes, a second, or that dose escalation from 1/4 milligram to 0.5 milligram or 0.5 milligram to 1 milligram.
It's finding that optimized dose, right, where they really respond. Yeah.
Yeah. Sometimes the people just, they need a higher dose, but because we're tapering to prevent nausea, they don't, their body doesn't really experience the full effect of it until they bump their dose
It's
up.
such a, balance there initially between minimizing the side effects, but finding the appropriate dose to get the beneficial effects, right?
You have to wait a couple of weeks, but we have people that have lost, some substantial weight within 10 or 12 weeks, 3 months. That we have people that have lost 30 plus pounds. So you have to wait for them to kick in, but it's amazing how well they work as far as weight loss goes, as far as, fixing someone's hemoglobin A1C level. And that's, we don't see a whole lot of diabetics, but we have a lot of people that are pre-diabetic and don't know it just because they've never had their blood work done, which is why I always encourage anyone to get their blood work done. Like, more information is never not going to be helpful.
Right.
I have a bunch of people that, I had no idea I was pre-diabetic. Like, I should do something about that.
Yeah.
But just the improvement. Somebody's pre-diabetic and it's like, hey, do you want to become healthier and not be pre-diabetic and lose 30 pounds in the process? Yeah, sure.
Before you are diabetic and maybe you haven't been going to a physician, you haven't been getting checked up on, and you had years of high blood sugar, feeling terrible, fatigued, damage all throughout your cardiovascular system and your kidneys, and all throughout the body. So it's, the eye, diabetic retinopathy. It's like, the sooner you can get those blood sugar levels under control and that weight under control. That's why we as Americans, right? Americans should be more proactive instead of reactive, right?
Yeah, it's generally better to head off problems before they happen rather than try to fix them after they come up. And that's true with hormones, hair loss. Obviously it's a lot easier to hold on to hair than it is to regrow it.
Right.
But yeah, generally if you can, catch something before it becomes a problem. And that's why a lot of our blood work was, our our full panels for males and females were designed to monitor things like hemoglobin A1C or prostate-specific antigen or prolactin, you know, to keep an eye on all these different things that could change over time. We monitor them, make sure everything's, you know.
So you said this has helped lower their hemoglobin A1C. I guess you want to talk about what that is?
So A1C is a measure of blood sugar over the course of, generally it's 12 weeks. You know, so when sugar enters the bloodstream, it binds to hemoglobin, you know, the protein in the red blood cells, and everybody has these sugar-coated hemoglobin cells, but people that have a higher average blood sugar are going to have a higher percentage. And so the A1C is just a percentage measurement of those sugar-coated hemoglobin cells.
Right, like the history of your blood sugar level over the previous 3 months. Because, you know, red blood cells typically live only 90 to 120 days. So 3 to 4 months, it's kind of giving you an idea of, if you're looking at hemoglobin A1C, you know, how well is your blood sugar being controlled or not controlled, depending on what you're doing with your diet, your exercise, any other drugs you may be on. But yeah, that's really interesting. That it's lowering that. You're seeing blood glucose control with these drugs. Yeah.
And your A1C is the best measure of, you know, being diabetic or pre-diabetic, because you can't, obviously we measure fasting glucose on all our lab panels. It's not a, you know, your blood sugar goes up and down throughout the day like a roller coaster based on what you're eating.
Yeah, and maybe in the morning you think maybe they're stressed, they get a big cortisol spike. Cortisol can cause the liver to dump a bunch of sugar in. That measurement may be off. It's like, oh, you know, your blood sugar's at, you know, 115, you're pre-diabetic. Well, maybe not. Maybe they're stressed. You know, stress is going to cause a rise in blood sugar. But yeah.
I did a lab review within the past couple of days, and a longtime client of mine. So I know his labs. I know kind of what health he's in. He's in amazing health. But his fasting glucose came back at like 135, 140. Normally you'd be like, oh, that's not good. But his A1C was 4.5. So his A1C was like in the normal range, as far away from pre-diabetic as possible.
Right.
I'm like, let me guess, you just weren't completely fasted that morning. He's
right.
Like,
yeah, hadn't eaten. Maybe he ate 5 hours before his blood was drawn. So yeah, you're at whatever you said, 135. And typically, you know, physicians diagnose diabetes when blood sugar's at 126 or above. So some physicians might have said, oh, diabetic, and then they start putting them on, you know, whatever. And it's like, well, that wasn't needed. Let's, look at A1C, or they shouldn't just be diagnosed on one visit. It should be like several, right? To get a complete picture. But
there's a lot of things that you shouldn't be doing.
Right.
that are still done today.
Yeah, I agree. Trying to think, do you have any other, this is one other question. We didn't even have it on our list, but maybe any like wild success stories where maybe somebody was like morbidly obese, like say their BMI is like above 40. And where they were maybe scheduled for like a lap band procedure or gastric bypass, Rowan-Y procedure, where they were scheduled for bariatric surgery, but then maybe you tried this route first, right? Because obviously less invasive is typically going to be what people want versus going in there and, being operated on.
Yeah. First of all, BMI is such an outdated metric. You know, even when I had my thumb surgery 2 weeks ago,
well, yeah, for you,
they had to talk about all the, hey, your BMI is 35 or 36, you're morbidly obese. And I'm like,
and they didn't look at you and say, well, you're solid muscle, that's why your BMI is high.
Right. Basically, all that says is, hey, someone that's 6'2" shouldn't weigh 245 pounds. But it's like, it doesn't take anything else into account. But talk about a success story. I did a consult with somebody in the past week, and I can't wait to see where he's at in a year, but he's been working with us for a year. He started at 298, 299 pounds, somewhere in there, probably 45% body fat.
Oh.
He's, a year later, he's sitting at 254, 258.
All right.
And that's while he's put on 21 pounds of lean mass. So he has a 45-pound change in overall weight.
But most of that is from fat mass.
21 pounds of more muscle.
And he's added muscle mass. Exactly what you want. Right. Yeah.
So he's lost essentially 60 pounds of fat mass and put on 20 pounds of muscle. Looks like a completely different person.
Now, of course, he's doing his resistance training, all that, the high protein intake, all that, along with the
Brazilian Jiu-Jitsu, and he's doing resistance training and doing, obviously the right medication protocol combined with the right lifestyle changes and the right activities, we see some pretty incredible results. But again, I can't wait to see where he's at in another year.
Yeah.
If he can get to his goal weight of 225, coming down from almost 300 pounds.
Yeah, that's amazing.
So
that is amazing. Anything else you want to mention?
I don't think so. Like I said, as far as weight loss goes, we really haven't seen anything like either one of these medications. I mean, even liraglutide, when it came out, was incredibly popular, but that was something that had to be injected much more frequently. Semaglutide and Tirzepatide have now become the gold standard. But again, every weight loss medication we've ever seen in the past doesn't compare to, just because of the forced lifestyle changes, just the overall physiological effects. We haven't seen anything like them, and we've had some ridiculous success with a lot of different people. So it's who doesn't want to lose weight and improve their overall health and blood sugar and A1C numbers, and
yeah,
it's kind of win-win.
Great to hear. How can new patients contact you or Pinnacle if they have questions about GLP-1 receptor agonists, type 2 diabetes, weight loss therapy, the other services you offer, or scheduling an intake appointment?
Yeah, so they can go to our website. It's pinnaclehealthperformance.com. They can follow us on Instagram at Pinnacle Health Performance. There's a lot of educational content we've been putting up about the GLP-1 agonists and other medications. They can email info@pinnaclehealthperformance.com, or they can call the office. The number is 804-404-2905.
All right. Well, thanks for another interesting discussion today, Adam. If you have questions for me about the KU Exercise Science program, send an email to jtaylor@ku.edu or call 913-897-8516. Thanks again for watching this episode of Fitness Facts.